Good afternoon. Today we will talk about shock. Okay. First of all, you have to be oriented with the contents of your circulatory system. You have blood, you have heart, you have simply blood vessels. Okay. So this is a closed circuit. Okay. And the blood is going to vital organs and non-vital organs. Non-vital organs like skin. Okay. So to know the types of shock, you have to be oriented about the cardiac output, the heart rate, systemic vascular resistance, pulmonary capillary wedge pressure, which is the measurement of left atrial pressure. Consider that. And GVP, jugular venous pulsations, which are the measurement of right atrium. Okay, and the blood pressure and the skin, which is considered temperature. Okay, so in hypovolemic shock, the problem here is blood loss internally or externally or fluid loss from extensive burns. So the amount of blood will decrease. So the venous return to the heart will decrease. So simply the cardiac output will decrease in hypovolemic shock. So the heart rate as a reflex will be reflex tachycardia. So the heart rate will be increasing. Okay. What is systemic vascular resistance? This is blood vessel state. Do you have blood vessel constricted, vasoconstricted, or vasodilated? Okay. So now we will clarify that. Okay. So we have the blood vessel state in hypovolemic shock. The systemic vascular resistance will be reflex vasoconstriction of the vessels. The vessels will vasoconstrict to compensate for this hypovolemic shock. So the systemic vascular resistance will be reflexly high. What about the left atrial pressure, which is known as measured by Swangan's catheter, known as pulmonary capillary wedge pressure, will be essentially decreasing. Why? Because the amount of blood here will be low. So the right atrial pressure will be low. Also, this is for jugular venous pulsations. So you will have GVP, the reflection of the neck veins, jugular venous pulsations will be low. Jugular venous pulsations will be absent or low. This is RAP, right atrial pressure parameter. But these are the pulmonary veins. This are reflection to your lung. So this PCWP, the pulmonary capillary wedge pressure, is measurement of left atrial pressure or left ventricular end diastolic volume. Left ventricular end diastolic volume. This will be essentially also decreasing. So both PCVW of the left atrial pressure and GVP pulsations, which are reflection for the right atrial pressure, will be decreasing. What about the blood pressure? The blood pressure, this is a shock. So the blood pressure will be essentially decreasing. What about the temperature of the skin? You will have cold peripheries. Why? Because the blood will be converted from non-vital organs to vital organs. So non-vital organs like skin, the blood reflexly goes to vital organs trying to surviving the body. So the non-viable organs like skin will have less amount of blood, so it will be cold or skin temperature will be decreasing. This is for the hypovolemic shock. Okay. What about the cardiogenic shock? The problem in your cardiogenic shock that your heart is not able to contract well. So the problem in this heart machine. So you will have the following. We will have low cardiac output because the heart is not able to pump blood, so you will have low cardiac output. The cardiac output is the amount of blood coming out of the heart because the heart is affected, so you have low cardiac output. According to the cause of cardiogenic shock, you can have tachycardia versus bradycardia because something like anesthesia or beta blocker, so you can have tachycardia versus bradycardia. Okay, regarding the systemic vascular resistance will be reflexly increased. Why? Because the peripheries try to constrict to maintain blood as much as they can. Okay, what about the reflections? The left atrial and right atrial pressures will be essentially high. Why? These will be high because the blood will be congested here because the blood is not able to contract this amount. So it will be here and here because the blood cannot go out because of the weakness of your heart. So the reflections will be raised GVBs, okay, and raised left atrial pressure because of the heart is not enabled to pump this amount of the blood. Essentially, the blood pressure, because if it's a shock, the blood pressure will be decreasing, the patient will be hypotensive. Also, the skin, as we said, the blood trying to convert from non-viable organs to viable organs, we will have decreased temperature of the skin or cold clammy peripheries. So here we are about the final septic shock. Septic shock, the problem in septic shock that we have infection. Okay, we have infection. Infection means what? Infection means that this infective or inflammatory process occurs releasing chemokines and cytokines. These materials, chemokines and cytokines, cause vasodilatation and edema with pooling of blood. So this vasodilatation here and here and here leads to high cardiac output because the amount of the blood will be high returning to the heart and we will have decreasing cardiac output. Also, we will have tachycardia, okay? Because the heart is trying to compensate to this vasodilatation by increasing its rate and increasing its cardiac output to maintain filling of this dilated blood vessels. Systemic vascular resistance here is a golden problem in septic shock that these peripheries are dilated, so the resistance will be low. Here, the systemic vascular resistance will be low. Okay, what about the pressures? All pressures will be low. Okay, blood pressure essentially and GVBs are low because the heart is well pumping to a dilated area, so the GVBs will be decreased and also PCWB. Okay, finally about the skin. So this is a golden to know that this the decreasing systemic vascular resistance in septic shock, and also increased temperature of the skin, you will have warm peripheries. Warm peripheries because of the vasodilatation caused by chemokines. So you will find warm peripheries because of vasodilatation and the peripheral increased temperature. Here we are, we have finished the interpretation of the parameters of shock. Now we will go to the file to make it more easy for us to know the treatment options, the diagnostics, and all of that. Here we will talk in brief about the shock definition and types of shock with their management. Okay, what is shock? Shock is a life-threatening circulatory disorder that leads to tissue hypoxia and also disturbance in the microcirculation, the microvasculature circulation. And there are many causes of shock, like cardiogenic shock as a result of acute heart failure or cardiac tamponade or whatever, hypovolemic shock, massive blood loss, and distributive shock. So types of shock, we have here the heart and have here the capillaries. Okay, so this heart, we will have hypovolemic shock, the amount of blood will be decreased. Okay, cardiogenic shock, the heart not able to pump blood well. Then we have obstructive shock, obstruction to the heart to pump blood, and we have many types of obstructive shock. Okay, so we have obstructive shock. Also, problem in the capillary, we have distributive shock. Distributive shock, like what? Like septic shock, which is the most common, anaphylactic shock due to allergy. The body will form hypersensitivity reactions causing the same as toxic metabolites here that cause vasodilatation. So here the problem is vasodilatation of the blood vessel. This is septic shock, this is anaphylactic shock, and this is neurogenic shock. Spinal cord injury leads to loss of sympathetic tone. Loss of sympathetic tone. This is very important. So, again, I will talk it again. We have cardiogenic shock, hypovolemic shock, obstructive shock, and distributive shock. Cardiogenic shock, hypovolemic shock, obstructive shock, and distributive shock. Okay, what about hypovolemic shock? We will have loss of more than 20% of the intravascular volume. And from this, we have grade 1 to 4 hypovolemic shock. We will have higher morbidity because of faster rate of volume loss. And if patients have multiple comorbidities, we will have poor compensation, then higher morbidity. What is the etiology of this shock? We have hemorrhagic and non-hemorrhagic shocks. Hemorrhagic shock, which is trauma, bleeding leads to internal or external bleeding, and also some injury to the internal organs and fractures of pelvis and lung bones. So we have also upper GI bleeding and postpartum hemorrhage. Postpartum hemorrhage, all of that are hemorrhagic fluid loss. We have also non-hemorrhagic loss like diarrhea, vomiting, surgical drainage systems, and burn, Steven-Johnson syndrome, increased insensible fluid loss. So maybe blood, maybe fluids. We have also third space loss and renal fluid loss. We have weak 3D pulse, we have tachycardia, we have tachypnea to compensate for this loss of blood. We have cold, clammy extremities with poor capillary filling time more than 2 seconds. We have narrow pulse pressure with hypotension if there is decompensated stage. So now we have types of hemorrhagic shock or classification: class 1, class 2, class 3, and the class 4. If less than 20%, less than 15%, up to 40%. Less than 15%, we will have heart rate less than 8, and we'll have normal, still normal blood pressure in both types 1 and 2. Okay? We will have also respiratory rate. Here is normal, but here the patient will be tachypneic up to 30. The urine output will be maintained above 30 ml per hour. Okay, the patient will be anxious and or confused and anxious here, but these stages of shock, the blood pressure started decreasing, and in class 4 shock, we will have confused and lethargic patient with absent urine output less than 0.5 ml per kg per hour. Okay, so this is patient is anoric, and we will have decreased blood pressure with tachycardia more than 140%. How to keep all of this information? Keep this number: heart rate 100, 100 to 120, and less than 140, but between 120, but if 40, 40, 40, like this, more than 40% of blood loss. Okay? More than 140 beat per minute with hypotension and tachypnea more than 35% with anoric patient, lethargic. This is type 4 hemorrhagic shock. We have to first detect the blood, from where the blood is coming to stop it. So we have to do ABCDE according to the ATLS protocol, ABCDE, and search for the cause of bleeding using ABCDE, exposure, then fast scan, and hemoglobin or hematocrit. Okay? Treatment by fluid resuscitation and the early consideration for the blood. Okay? Now for the cardiogenic shock. So cardiogenic shock, this is systolic blood pressure less than 8 millimeter with urine output less than 20 milli per hour with normal or elevated left ventricular filling pressure. Here, the pathophysiology is the stroke volume, the amount of blood ejected from the heart per minute. This is will be decreased. So the stroke volume will be decreased, okay? And the systolic less than 90 millimeter mercury. Okay, we have non-obstructive cardiogenic shock and obstructive cardiogenic shock. Non-obstructive like MI and cardiac arrhythmias, and obstructive cardiogenic shock. Here it is obstructive shock or obstructive cardiogenic shock, the same reasons. The same known popular 5 reasons: tension pneumo, cardiac tamponade, constrictive pericarditis with restrictive cardiomyopathy, and pulmonary embolism. Here, the heart is blocked. The heart is prevented to eject, to pump, to make, because it is obstructed. This is simply. So we have like tension pneumothorax. The lung collapsed over the heart. Cardiac tamponade, some fluid, maybe massive fluid present in the pericardial sac, obstructing the heart to pump blood. Like constrictive pericarditis, the pericardium itself make as constriction to the pumping heart. Then some cardiomyopathies, like restrictive cardiomyopathy, like in amyloidosis, sarcoidosis, whatever, we have many causes of restrictive cardiomyopathy. The heart is prevented to pump blood. Lastly, the pulmonary embolism, massive pulmonary embolism. This is a type of cardiogenic shock. Why? Because the pulmonary trunk itself is obliterated, preventing the heart from pumping. All of these are types of obstructive cardiogenic shock. We have also weak pulse, as we said, tachycardia, to the heart trying to compensate, but later on, if this tachycardia, according to the cause, may be bradycardia, okay, but the heart beating rapidly, okay, but less strength, okay. Also, we have, as we said, the skin, the peripheries compensation system will try to convert blood from non-viable organs like the skin to viable organs. So we have called the clammy peripheries with poor capillary filling time. As we said before, the heart is accumulated and congested of blood. So the pressure inside the heart will be high because it is obstructed. So we have both GVBs and VCB, GVB and VCWB will be high. The pressures in the right atrial pressure will be high. The lap and wrap are high. So the standard neck veins, elevated jugular veins, and we will have also hypotension if this compensated stage. We have to do cardiac markers to exclude MI, like high troponin, troponin T, or troponin I, troponin T to identify acute coronary syndrome, ECG to identify MI, cardiac arrhythmias, pulmonary embolism, echo to identify valvular lesions. Okay. Also, we can do pulmonary artery catheterization, which is PCWB, which will be high in cardiogenic shock. Treatment, CPR if necessary, cardiopulmonary resuscitation, and myocardial infarction. If the systolic blood pressure less than 70, from 70 to 100, according to that, we use norepinephrine versus dopamine. Okay, this is the new guidelines. Systolic blood pressure less than 70 millimeter mercury, we will use norepinephrine. Systolic blood pressure from 70 to 100 millimeter mercury, we will use dopamine. Okay, we can do reperfusion therapy like PTC, PTCA and thrombolysis. If pulmonary congestion, we can use furosemide, Lasix, with diuretics for treating the pulmonary edema. Vasodilators like hydrazine and isosolide dinitrate used to decrease the afterload. Okay. If we have cardiac tamponade, we can do percardiocentesis in the subxiphoid approach. Pulmonary embolus, if this is non-massive, anticoagulation used by low molecular weight heparin followed by warfarin. If this massive pulmonary embolism, we can use thrombolysis versus embolectomy. If tension pneumothorax, we will use needle decompression followed by chest tube, and according to the new ATLS sedation, we will make needle decompression in the fifth intercostal space, mid-axillary line. Yes, why? Because they have found that obesity interfere with the second intercostal space, mid-clavicular line. So now we use fifth intercostal space, mid-axillary line. So here, very important to know that in obstructive versus non-obstructive cardiogenic shock, we never use fluids, heart shock hate fluids, okay? Because this will exacerbate the cardiogenic obstruction and we will exacerbate the symptoms and will aggravate the condition. Okay, no need for the other information. Okay. We have now distributive shock. How to SA node, septic, anaphylactic, and neurogenic. Those are NAS or SAN or SA node distributive shocks. Okay. Capillary leakage, like in sepsis and anaphylaxis, or systemic vasodilatation with pooling of blood. In both causes, plus neurogenic, you will have loss of the sympathetic tone, so the blood vessels will be dilated like this. So we have septic shock, neurogenic shock, and anaphylactic shock. Septic shock, this is abnormal host response to an infection, leads to release of chemokines and cytotoxins, leads to capillary leakage and systemic vasodilatation. This leads to acute and life-threatening organ dysfunction with circulatory and metabolic with cellular abnormality. We have now very nice diagram for SIRS, sepsis, severe sepsis, septic shock. Okay. SIRS, systemic inflammatory response syndrome. Sepsis, severe sepsis and septic shock. Here, SIRS is TT family. T family means we have temperature, we have tachypnea, tachycardia, and TLC, total electrostatic count. Okay, we have TLC outside the range from 4 to 12,000 cells per cubic millimeter. Okay, we have temperature out the range of 36 to 38 Celsius degrees. We have tachypnea. Okay, we have also tachycardia more than 90. Okay, respiratory rate more than 20. So again, this is SIRS. We have temperature outside the range from 36 to 38 Celsius degrees. We have tachycardia, more than 90 beats per minute. We have tachypnea, not tachycardia, this is tachycardia, this is tachypnea, more than 20 per minute. We have TLC, total leukocytic sound count outside a range from 4 to 12,000 cells per cubic millimeter. This is called SIRS, okay? Systemic inflammatory response syndrome. So at least of these PTTTT are enough to say that we have SIRS, systemic inflammatory response syndrome. If we have SIRS, those two SIRS, okay, plus confirmed or suspected infection, this called as sepsis. Okay, if we have two features of SIRS plus confirmed or suspected infection, this is sepsis. But what about severe sepsis? We will have also two SIRS plus confirmed, documented, or suspected infection, plus signs of end organ failure with hypotension and lactate more than 4 millimole. Okay, so lactate and the hypotension, we will have severe sepsis. So sepsis plus signs of end organ failure like hypotension or lactate more than 4 millimole per liter, then we will have severe sepsis. What about septic shock? Septic shock, we will have all signs of severe sepsis plus signs of end organ damage, which are persistent despite fluid support and inotropic support. So septic shock is the same definition of severe sepsis, but which is refractory to fluid support or inotropic support. Okay, I hope that this is clear for you. So the problem of septic shock is the infection. Okay, but we will never treat infection first. We have to treat fluid resuscitation according to ABCD. E, we will do fluid resuscitation. We will have vasopressors, first line, septic shocks, SE, so norepinephrine. Septic shock, SENE. First line, norepinephrine. Second line is epinephrine. Working on the vasodilated peripheral blood vessels, make them vasoconstricted, alpha blocker. Early initiation of broad spectrum empirical antibiotic therapy, and late on according to culture sensitivity. We have to surgically interfere to eliminate the site or the focus of infection, like in necrotizing fasciitis, peritonitis, whatever, the cause of this infection. We have neurogenic shock, loss of sympathetic tone. The problem in the spinal cord itself, damage to segments, hemisection or complete section, or damage to the spinal cord. So this will lead to loss of sympathetic tone, okay, leads to peripheral vasodilatation and pooling of peripheral blood. So we will have also in this neurogenic shock, we will have also pooling of blood, decreasing systemic vascular resistance, the same like septic shock. The same, okay? We have spinal cord injury, we have spinal anaesthesia, traumatic brain injury, cerebral hemorrhage, poisoning, and severe pain. All these causes will lead to loss of sympathetic tone, like epidural or high epidural. Spinal cord injury is the most common cause, and nowadays you have to be oriented why the patient is bradycardic, why the patient is has low systemic vascular resistance with pooling of blood due to loss of sympathetic vascular tone due to neurogenic shock. Here, skin will be warm and flushed. Why? Because as we said, the problem in sympathetic pole, so we will have vasodilatation. So also like septic shock, as we said before, septic shock, we will have flushed warm skin, and also in neurogenic shock, we have warm flushed skin. Okay, what is the treatment of, so we have also bradycardia because of loss of sympathetic system, which make tachycardia and make the heart rate increase. So the loss of sympathetic tone leads to bradycardia. So bradycardia is not a feature of cardiogenic shock, never. Maybe the patient is brady or tachy or normal cardia in cardiogenic shock. But in neurogenic shock, you will find the patient is bradycardic, okay, because of sympathetic system loss, sympathetic tone loss. So we have both hypotension with not the heart cannot maintain reflex tachycardia. Why? Because the sympathetic system responsible for that is absent. So this sympathetic system that responsible for tachycardia is absent. So the patient will hypotensive and also bradycardia. The treatment, fluid resuscitation and atropine to treat bradycardia. If fluid resuscitation fails, you have to think like that. If fluid resuscitation fails to increase mean arterial blood pressure more than 90 millimeter mercury, we have checked brady. Bradycardia is present, use epinephrine to simulate like cardiac arrest, like it, because we have bradycardia. So use epinephrine. But if bradycardia is absent, no bradycardia, it is time to use phenylephrine. Note that we have in a patient who develops hypotension following high energy trauma, neurogenic shock if diagnosis of exclusion that's made after hypovolemic and obstructive shock. In trauma patient, you have to think that this is hypotensive shock. Then obstructive shock of pulmonary, not pulmonary contusion, of tension pneumothorax, so hypovolemia, obstructive of tension pneumothorax. Then later on, think if the patient is bradycardic, not responsive to vasopressors, or so we will think in neurogenic shock. Okay. Lastly, we have anaphylactic shock. It is also airway. Even if the patient in respiratory failure, you will do intubation. We think in ABCD manner: airway, breathing, the adequate ventilation, and breathing. Then circulation, check the circulatory system. Take bloods for lab and give two IV cannula and check for any source of bleeding like that. And measure blood pressure, capillary filling, pulse oximetry, then disability, check GCS and AVPU. Then exposure to discover more. Then reassess and re-evaluate. This is called ATLS protocol, Advanced Trauma Life Support Protocol. So anaphylactic shock, you will think the same like that. The patient is hypotensive, tachycardia, reflex tachy, flushed with each skin because of the anaphylaxis. We have also maybe bronchospasm and laryngeal edema, angioedema. Okay, so treatment of ABCDE. Then the main stem is epinephrine IM, and if important, as we said, we think ABC, airway support, even intubation or nebulization with beta agonist, albuterol, salbutamol, whatever, then epinephrine and glucocorticoids. What are the diagnostics for any shock? You have to think like that. Test the patient responsiveness. A, array, breathing, circulation, disability, and exposure. And take baseline GCS scoring, okay, Glasgow score, Glasgow scale scoring system. Then check skin color, temperature, and capillary filling. Monitor heart rate and the blood pressure and circulation. Okay, shock index or Alger's index, the pulse rate, okay, measure the pulse over the systolic blood pressure. From this, we can measure the shock index. If the pulse rate over systolic blood pressure more than 1, this is called positive shock index, may indicate presence of shock. Oxygen saturation by pulse oximetry, then, as we said, 2 wide bore cannula, catheterize the bladder to measure the urine output, and start IV fluids. Warm crystalloids. Then draw blood for renal function tests. And if you are suspecting MI, you can check troponin I, troponin C, and ABG clotting parameters. Later on, electrolytes, liver function tests. Insert CVB to measure central venous pressure if necessary, and also, if necessary, the same pulmonary artery catheterization. Okay, what is the difference of shock? This that we have mentioned before. Okay, we have cardiac output, we have heart rate, CVB or GVB, okay, whatever. Left ventricular end diastolic pressure, it is also the same like this one. So GVB, pulmonary capillary water pressure, CVB, peripheral or systemic vascular resistance, mixed venous oxygen saturation. This is indicator for the oxygenation. Here in hypovolemic shock, as we said before, the problem in blood, so the blood is low, so the cardiac output is low, reflects tachycardia. Then the CVB will absent or low. Why? Because the amount of blood itself coming to the heart with venous fill is low. Also, both of them the same as we said before. Low PCWP and left ventricular end diastolic pressure. Systemic vascular resistance due to reflex vasoconstriction of the blood vessels trying to compensate for this will be high. Mixed venous saturation of oxygen will be low. Why? Because the low amount of blood. This is a hypovolemic shock. Okay, what about the cardiogenic shock? The problem is that your heart is not able to pump blood, so the cardiac output will be low. The heart rate, as we said, may be tachy or brady, according to the cause of cardiogenic shock. CVB, as we said, you will have congested heart, so we will have high CVB, central venous pressure, with visible GVB or raised jugular venous pulsation. Also, this is called right atrial pressure. Also, We have left atrial or left ventricular end diastolic pressure, which is the PCWP, will be also high because the heart having amount of blood could not be pumped out because this heart is weak. The systemic vascular resistance reflects vasoconstriction to maintain the blood supply. This is reflex, so the systemic vascular resistance will be high. Also, the mixed venous saturation of oxygen will be low, indicator for saturation. Okay, so the problem in septic shock, so distributive shock, we have septic shock, neurogenic shock, and anaphylactic shock. SNO, remember this. Septic shock, the problem in septic shock is inflammatory or infective bacteria or whatever leads to release of chemo and cytotoxins and chemokines leads to vasodilatation. So we will have vasodilatation leads to more blood coming to the heart, more cardiac output because of reflex tachycardia to trying to fill this dilated vessel. Okay, we will have also decreasing because the heart will be trying to empty itself by tachycardia by increasing the cardiac output to maintain the periphery, the pool of blood peripherally. So we will have low force pressures of right atrial and left atrial pressure. We have also systemic vascular resistance. Here is a problem that the peripheral vasodilatation means low resistance, low resistance. So the systemic vascular resistance will be low. But the mixed venous oxygen saturation will be high because of the vasodilatation and the hyperdynamic circulation. The mixed venous oxygen saturation will be high in this case. So septic shock is known by warm, clammy peripheries, tachycardia, cardiac output high. Okay, systemic vascular resistance is low with again warm, flashy peripheries. What about the neurogenic shock? Neurogenic shock, you will have loss of sympathetic tone due to loss of sympathetic tone, vascular tone leads to also peripheral pooling of blood. Here, the causes infection and sepsis. Here, the problem is spinal cord injury, toxins, so many causes of anesthesia, epidural, high epidural, all of that. We will have both have low cardiac output because the heart itself is bradycardic, so we will have bradycardia in neurogenic shock, not cardiogenic. Okay, we will have bradycardia. Okay, because of bradycardia and low cardiac output and loss of sympathetic tone, we will have low pressures inside the right atrium and left atrium because the heart strength is lost because of loss of sympathetic tone. So we will have also CDB is low and peripheral vascular resistance is low. Okay, why here? Because of the peripheral pooling of blood, like septic shock. the same as septic shock. Also anaphylactic shock, but later on, the because of the heart and the blood vessels, both of them, so the mixed venous oxygen saturation will be low, no, not high. Anaphylactic shock, we will have in anaphylactic shock hypersensitivity or hyper-responsive body towards allergen, like bee nut allergy. You will have pooling of blood, the same as septic shock and the neurogenic shock because of vasodilation. So you will have also reflex tachycardia. Here it is reflex tachycardia. This is the difference between here because the heart, no sympathetic affection. But here it is just pooling of blood like this, okay, like the septic shock. So we will have reflex tachycardia. We will have low cardiac output, okay, because of pooling of blood, okay. We also have low pressures inside the right and left atrium. We have finished. I hope you subscribe our channel for more lectures and you can request any unknown or any unclear topic in surgery or medicine. Thank you.